can hear you. Please.
Good afternoon, everyone. Our faculty for today's session is Dr. L. Ramakrishnan. He is a public health professional and vice president at NGO Sati. For the past 25 years, he has been working towards inclusive healthcare, justice, social protection for communities marginalized on account of gender, sexuality, HIV, TB, and other factors. He has been contributing towards developing the NCRT gender sexuality module for teachers, LGBTQI inclusion in the 2019 mental health policy of Tamil Nadu, and the transgender health curriculum for training nurses. He has facilitated gender sexuality sessions at IIT Madras, Stella Maris College, Indian Medical Association student chapters, and Indian Psychiatric Society conferences in Manipur, Odisha, Gujarat, and Kerala. Warm welcome, sir. Over to you.
Yeah, thank you very much. I'm just trying to display a slide here.
So, Ramki, while you
have,
I think you do have sharing rights.
Okay.
While you do that, I just wanted to quickly make a mention to the rest of the group that one of the ideas behind the foundation course for palliative care is not just to understand palliative care, but to also understand the various communities that we serve and the communities that get left behind. And while all of us might have different ideas about what it is to be part of the LGBTQI movement or part of the community, we felt that it was quite essential to have a session sensitizing us in more detail to to some of the challenges, to some of the value systems, and certainly some of the healthcare issues that the community faces. So, Ram, we're ready for you, and I'll hand it over.
Yeah. Thank you very much, Smriti, and thank you, Emil, for the introduction. So, I have to apologize because I'm in my office and today the internet connection is particularly bad. So if it goes off, please hang on and I'll try to get back. So yes, thank you for the opportunity, and it's great to be here with the palliative care cohort again. I will be speaking about broad concepts related to gender and sexuality, and then focus a little bit on the mental health impact that the lack of acceptance from society and culture has on the LGBTIQ community, with specific reference to the stressors from family, society, health, and law. And then maybe a few frequently asked questions, and we can open it up for discussion. I'm going to quickly go into gallery mode and ask you all, how many of you have actually heard of LGBTIQ issues? Can we get a show of hands? Let me stop share for a second. Yeah. So could you all put your hands up, if either virtually or using the hands up button? Yeah. Yeah, Dr. Nupur, Rosina, Harpreet. Okay, so would you, and let me see, there are people in the other, no one else, just three people have raised their hands. Could we hear from you a little bit about what has been your exposure? Could we have you share? Can we go to Dr. Nupur first? Yeah. Can you unmute yourself? Or is it possible for someone to unmute? Yeah. Can someone help Dr. Nupur unmute herself? Yeah. Go ahead. Yeah.
Sir, could you please repeat the question?
Yeah, so I just wanted to hear, you raised your hand when I asked about awareness or familiarity with LGBTIQ issues or having met LGBTIQ people. So could you share a little bit about your prior exposure?
Yes, sir. So, sir, when I was working in Bombay, in Mumbai, emergency services in railway, central side. So there was this few times I came across an LGBT means from community, and I was not, because of my medical school education where I was not taught how to do the examination or question such things. It was difficult for me, but I tried, and I could not understand the issue at that moment.
Okay.
Now
Great.
also I have difficulties.
Okay. And are you referring specifically to the Hijra or Kinnar community or
Yes,
some other
yes, that's right.
subgroup? Okay.
Hijra.
Hijra. Okay. So yeah, Hijra are like one aspect of the LGBTIQ community that we definitely will be discussing. So thanks for sharing. And Harpreet, over to you. Can you unmute yourself? Yeah.
Good afternoon, everyone. So my knowledge about all of these issues is very,
A little
very
volume, please. Yeah.
yeah. So my knowledge about all of these issues is very, very limited. And but I've had a personal experience in the sense that they were friends. My son's friends. Some of them were gay, and the discrimination that they would face would be. It was very sad. And I would just look at them as young children who've come from all over the world to study, and yet, there's this discrimination. And I've seen things like emotional love, and that's being ridiculed. And so for me, it's something totally different. I would look at them as human beings, and whereas people would look at them as something very alien. And so yes, I only know about discrimination. That's all.
And may I ask how old these children were when you met them?
They were in their early 20s. They were studying, all of them in college.
Okay, awesome. I mean, not awesome that they face the discrimination, but that you had an exposure through your son, and your son had friends who were comfortable being open to him. So that's great to know. Yeah, thanks. Anyone else would like to share? I thought there was a third person who had raised their hand. Could you unmute and go ahead? Yeah.
I would like to also share my experience.
Sure.
I recently had a patient, a young lady who came with like a lot of depression and very highly distressed. The family members first told me as if it was some psychotic breakdown. The family members told me like, she thinks she's a man. She thinks she's a male, but she's a female. So when they first told me, I thought, okay, what is going on? And then when I talked to her, she told me she doesn't like her body. She strongly feels like she's not supposed to be born a woman, that she wants to have her sex changed. She wanted to tell me, give her some advice on, how much the surgery is going to cost, what is it going to do to her life, how to make her family understand that she's not going mad. So that was the first time I experienced something like that, and I really didn't know what to do because that was my first time. So yeah.
Okay. How long ago was this?
Just like last year, December, I suppose. Yeah.
Okay. And where
Just
in the
2 months
country, if I may ask? Yeah.
No, here in India, Assam. She's from Assam.
Okay. I see. Okay. So the individual seems to be a transgender man, basically someone who is biologically female who identifies as a man. So we definitely will look up that. And also, in case you're still in touch with the person, we can suggest people who can help in Guwahati and in Dibrugarh. I don't know where the person lives, but yeah, there's definitely options there. Dr. Snigdha Ghosh, over to you, please.
Yeah, hi. Actually, I want to share my experience. So I have one of my friend. She was my school friend. So after school, actually, we didn't meet for around 6 to 7 years. But after that, when we met, so I get to know that she had gone for a surgery for sex change. So after that only I came to know about her experience throughout the journey. Actually, from then only it's a totally like superstitions in the society know that a girl is a girl biologically. If a girl is a girl, then if biologically a boy is a boy. So what happened to her? She was bounded in a physique of a girl, but mentally she was a boy. So likewise, she wanted to change her gender, like for surgery, but her family was not supportive. But for what she need to gather amount, like the money. So what she did, she gone for many type of a job and to for savings. No, after that she went for surgery, but till now her family is not her supported. But the good thing is that she like now she's he, so he got married. He had a wife also, and they are living happily. So what happens? No, in our generation we can accept this change. But what happened to our our older generation? No, they are not accepting this thing. So this is a big gap with the families, with the generation gap. And like I feel so in the future generation, no, so many of us and maybe the future generation will easily accept these changes, but now it's a big gap because of the generation gap and because of this acceptance. No, the people who want to go for surgery also, they are afraid. Like what will be the circumstances after the people knows about their whatever they are thinking, like they what if they change their sex, go for surgery, so what the people will accept, how the people will accept, whether the family will be accepted or not. So this is the problem in the society, so what I have experienced from my friend.
Okay. And Dr. Snigdha, this was in which part of the country and when?
It's in Assam, Jorhat.
Okay, great. Yeah, thank you so much.
Thank
Is there anyone else who wants to share? If not, I have a different question which I'd like one or two people to answer. Is why are we discussing LGBTIQ issues in a session on palliative care? And I think Smriti has already given a big hint, but I'd like to hear from maybe a couple of you. What, in your thinking, why is it relevant? Yeah. Anyone? Tabinda? Yeah. Or anyone else? Yeah. Go ahead. Yeah. Perhaps someone who hasn't spoken yet, we could give someone else a chance. Yeah. Would anyone like to hazard a guess, or just their impression of why this is relevant to a course on palliative care? Yeah, Dr. Swarnalatha.
Because of the
okay, Saju, go ahead. Yeah.
Because of the very fact that as a social worker, you may come across transgenders also. They are also part of the community, so you should be aware of basically their issues.
Okay. Yeah, thanks, Saju. Swarnalatha, did you have something to say since you've unmuted yourself? Yeah.
Yeah, they also need all the basic infrastructure facilities like all of us, right? Be it a healthcare system, be it palliative care, everything is required for them also.
And do you think these services are available?
Maybe not.
And why do you think that is?
We don't know how to deal with it.
Okay.
Second is, they are also not aware of where to go and get what services. Even the basic services, many of them are not aware of.
Okay. Yeah, excellent points. Thank you so much. Tabinda, please go ahead and unmute yourself. Yeah.
Yeah, good afternoon, sir. So basically in my master's, I have read about these LGBT things like lesbian games. And then after that, there were some more additions to it. But the place where we are living, like in Kashmir particularly, lot of discrimination I personally have seen, not only in terms of healthcare, but from the moment they're born in a family, hijras I'm talking about, there is non-acceptance of in their own families. They are being treated very ill, and their livelihood, like there is no consideration regarding that also. And when it comes to healthcare, many times they face a lot of discrimination in the hospitals or other settings. So as a social worker, there comes I personally feel that there is really a high need that there should be like the palliative care, there should be a lot of involvement done, lot of things need to be done for their proper health care or for the other things. Since I work in oncology department, I have myself experienced there that when these people come with their different diagnosis, many times a kind of different behavior of doctors or nurses, I have seen that they are being not treated the same way like other of the patients. So that's what I have personally experienced.
Yeah, okay. Yeah, thank you. These are very valuable insights. And I think that we can think about the different experience or the discrimination faced by people who look different or behave differently, like visibly transgender individuals. But one of the things we will be discussing here also is for individuals who are gay, lesbian, or bisexual and do not look visibly different, and the rest of society, including the healthcare system, assumes that they are heterosexual, like the mainstream, and that invisibility can also pose problems, just like the visibility can pose problems. The visibility may pose problems of overt stigma and discrimination. Invisibility means that the kinds of questions the healthcare provider is going to be asking, for example, who is your sexual partner, or who is your next of kin, who is your immediate family, these questions don't get asked, or they get assumed to be always the biological family. And as some people have already mentioned, the biological family itself can be a source of stigma and discrimination towards the LGBT family members. Harpreet, you have your hand up. If you want to make a quick point, please go ahead and then I can continue. Yeah. You had your hand up. Yeah, go ahead.
Yes, yes. So essentially, like I said earlier, it all boils down to discrimination. And in today's time in our country, what we see is, people fighting for a minority status based on a whole lot of factors. But I feel that these are the people who are marginalized and actually minority, and they deserve. There were no rights for them. There were no jobs available for them. And it's good that today, we are accepting them in our society. But I was just recently reading, and there are references in our old texts, our ancient texts, where they were not marginalized. Neither was there a discrimination against them, nor was something extra offered to them, but definitely they were not, considered as anything less or anything more. And I find it very strange that after centuries and centuries, where human beings are today supposed to be much more evolved, and it's sad that we have come down to a situation where we have started putting these differences. And so according to me, I think it all boils down to, like you said, it's all about discrimination, and they deserve in today's time, that they deserve to be treated as equals.
Yeah. Okay, thanks. So far, most of the discussion has assumed that LGBTIQ people are they are the other, and often there is a lack of recognition that LGBTIQ people can be among us also. So people need not necessarily look different to be part of the LGBTIQ community. So what are some of the assumptions we make? We make assumptions that service providers, whether counselors or doctors or caregivers of other stripes, are all non-transgender, non-gay. They're all heterosexual and cis. So that itself can be, a problematic assumption. Someone earlier, I think it was Dr. Nupur, spoke about the medical textbooks and how the medical curriculum does not really deal with LGBTIQ issues. A colleague of mine, Dr. Samira, who's also known to Smriti, and I have analyzed medical textbooks, both MBBS and MD, in a variety of disciplines, nearly 12 disciplines. And yes, in many places they are not discussed, but in places where they are discussed also, the material is completely outdated. To give you an example, homosexuality was removed from the World Health Organization International Classification of Diseases as early as 1990. But even current MBBS textbooks, which are often just reprinted versions of older books, carry the reference to homosexuality being a psychosexual disorder. You will find this in STI, you will find this in forensic medicine, you will find this in Bhatia, and a lot of the common psychiatry textbooks as well. So there is also a problem that the medical education in India and the nursing education hasn't really caught up. I think clinical psychology and counseling psychology fare a little better than some of the other disciplines, but still there's a lot of work to be done. So in summary, the combination of social prejudice and stigma, things may have been different a long time ago, but right now everybody assumes that every other individual, especially a family member, should not be or ought not to be a member of the LGBTIQ community, and if they are, there are risks of invisibilization, also risks of stigma and discrimination. So we'll try to look a little bit at the diversity within the LGBTIQ communities, and then a little bit at the discrimination and the different forms it can take within families, within healthcare, within education systems, within the workplace, and within law, and how this really impacts health-seeking behavior, including but not limited to palliative care. So I'm really excited and impressed by the breadth of experience that people are coming here already with, and I'm sure that while a few people have spoken up and all of you all have expressed views of empathy towards the community, that there are probably some of you who've had growing up and education or religious sermons talking about homosexuality being unnatural and leading someone to hell. So there are certainly all of us, and I'm not singling out a particular religion, many religions also do have this notion that that homosexuality is immoral, etc., etc. And in India, what we see is a situation almost diametrically opposite to what you would find in like the global north, in Europe or North America, where in India there is a certain amount of, I'm not saying it's 100% acceptance, but there is a certain amount of understanding and maybe sympathy for transgender people, particularly transgender women, people who are assigned male at birth and who identify as women or third gender like hijras. But there's a lot of hostility still towards gay, lesbian and bisexual people. In the global north, you see almost the opposite. There's a lot of acceptance of gay, lesbian and bisexual people. There are gay weddings, marriages recognized in many countries. If a person is an American citizen or a Canadian citizen, they can legally, get residential rights for a green card for their spouse of the same sex, etc., etc. So I think somewhere when we look at our religion and our sculptures and so on, or references to, let's say, Ardhanarishwara or Shikandi, etc., we always see examples of people crossing gender, like Mohini, Vishnu becoming Mohini, or Shiva in the Ardhanarishwara form, etc. But we don't see that many references to men having love for each other or sexual love or physical relationships with each other, or women with each other. But there are depictions of some acts in Khajuraho and Konarak and even in some of the South Indian temples. But overall there is a sense among the majority of population that transgender people are very much part of Indian culture and society and tradition. But gay, lesbian and bisexual people are somehow, they are rebelling against society, or they are trying to be westernized, or all of this is a Western influence. There are a lot of misconceptions. So we'll try and look at all of these in the limited time available, and I'm looking forward to more discussion. So I'm going to go back to my slide. So when we look at LGBTIQ issues, there are a few different things that we have to understand. Like when I asked about LGBTIQ, some of you answered specifically with reference to transgender. So transgender persons are different because of their what is called gender identity, and gender identity is something which is different from sexuality. So I'm going to walk you through some basics of sexuality, gender identity, gender expression, and a fourth component that we call sex characteristics. And collectively, whether there are people use terms like LGBTIQ or other terms in other languages, we are basically talking about diversity of sexual orientation, diversity of genders, and diversity of sex characteristics. So let me try to break this down in a simple way. If anyone, I'm not able to see right now if anyone raises their hand, so feel free to speak up because I can only see my PowerPoint slides. So sexuality is a sum total of sexual orientation, which is simply put who someone is attracted to, sexual behavior, who someone has sex with, and sexual identity, how someone identifies. So when we talk about sexual orientation, if you have a man attracted to other men, predominantly to other men and not to other women, we say the person's a homosexual man or a gay identified man. Similarly, if you have a woman attracted to other women, predominantly or exclusively, and not attracted to men, we say that person is a homosexual woman or a lesbian identified woman. Behavior is not necessarily the same as orientation. So, for example, if you look at a situation in India where you may have, for example, a woman who's attracted only to women, but because of being in a conservative family, she's forced to get married to a man and forced to have sex with him. Her orientation is not towards men. Her sexual orientation is homosexual. But her behavior, because of her forced marriage, is towards men. So the important point to understand here is, by looking at someone's sexual behavior, you cannot conclude what their orientation is. And that in society, there is a very strong emphasis on male-female relationships and marriage and begetting children. So people who are of a non-mainstream orientation, like a man attracted to the same sex or a woman attracted to the same sex, will try to hide their orientation unless they are in a very broad-minded family and a society or other environment that accepts them. The last aspect of this is sexual identity. So someone identifying as gay or lesbian or bisexual is their identity. And I bring this up because there are people with a different sexual orientation, but who may be from a non-English speaking background, from a non-metro city, or from an older generation, who may never even have heard of terms like gay and lesbian and bisexual, but still their attraction may be different. So don't expect that people of a different sexual orientation may necessarily have the words to describe themselves in terms of identity. And secondly, don't assume that people whose sexual behavior is frowned upon by mainstream society will necessarily come out and disclose it. So to give you an example, a woman walks into a gynecologist's clinic with some issues. Maybe it has to do with menstruation, maybe it's some other gynecological issue. And the gynecologist will ask the question, are you married? So this question is basically, there are a lot of things hidden in this question. Hidden is the assumption that if she's a woman, her sexual behavior will be only in the context of a marital life. So people who are having sex with men, women who are having sex with men outside of marriage, or women who are not having sex with men or even interested in men, and who are lesbian, for example, will not even be able to come out and disclose their orientation or behavior, because the doctor is starting from the assumption that are you married is the appropriate question to be asking her about her sexual behavior, which she may then try to correlate with her sexual health. So we have a lot of these assumptions even within the healthcare practice. So the takeaway lesson from this slide is that if you are a care provider and you have an individual who's coming to you for care and you need to talk to a family member, don't just ask if it's a woman, do you have a husband, or if it's a man, do you have a wife. You can ask about biological family. You can also ask about husband and wife if you think necessary, but you can also broaden up the conversation. Do you have a boyfriend or girlfriend, or even better, do you have a significant person in your life? So keeping the questions open-ended can sometimes surprise you, where people may actually feel comfortable to say that no, I do not have a husband, but I have a female partner with whom I have lived for X number of years, and that person may be really the one who the client wants to be consulting in terms of hospitalization decisions or end of life decisions. So whatever the law says or doesn't say, as healthcare providers, I think our focus should be universal access to healthcare for everyone, and principles of dignity and social justice, and especially when we are talking about somebody who's for whom we've exhausted curative options and we are only palliative options, or we have to be really thinking about who is the support system this person has, and let's not drive the discussion based on our assumptions of who they ought to be partnered with. In palliative care, and I gathered this from sitting in on one of the introductory courses, we talk about facility-based services, we talk about palliative care providers who may come over, and we talk about family members. So for a lot of people from the LGBTIQ community, the biological family may not actually be their family members, or they may be single, or they may have a partner of the same gender that they feel embarrassed to talk about or afraid to talk about for fear of eliciting a negative reaction from the care provider and losing what little help that they badly need, whatever help they badly need. So yes, you may have religious or moral hesitation about accepting a different sexuality or a different gender, but just following the Hippocratic principles of do no harm, it is and just provide care. I think it's good to be attuned to the person's circumstances, their orientation, their gender identity, and meet them where they are. Okay, so here's a small graph, pair of graphs. So if you look at sexual orientation, the three-dimensional graph on the left, you talk about attraction to men, attraction to women, and attraction to non-binary trans persons. Now I've added a new term, non-binary. So we always think of transgender as a third gender, but it's not always the case. There are transgender people who identify as men. Like I think some people gave the example of their friends or their clients who were biologically female but who identified as men and who did not identify as third gender. So in the principle of recognizing and respecting people for who they are, we will only identify them by who they want to be known as. So if it's a person who is biologically female but who thinks of themselves as a man, regardless of whether that person has had surgery or not, refer to that person as he and not as she. Don't say she became he after the operation or he became she after the operation. The Supreme Court of India has said that regardless of whether they've had surgery or not, regardless of whether they are on hormone therapy or not, their pronouns and their gender must be respected, and that gender may not be equal to the gender associated with their biological sex. So that lecture aside, there are transgender people who do not identify as either men or women, and we refer to them as non-binary. So the point of this graph is an individual may have a sexual orientation anywhere in this three-dimensional space. They could be attracted to nobody, in which case you would say they are asexual. They could be attracted to anybody, in which case you would call them pansexual. They may be attracted only to the same gender and not to the other genders, in which case you would say they are homosexual. They may be attracted only to the opposite gender and not to any other gender, in which case you would say they are heterosexual. So we often have a wrong impression that if someone is attracted to women, they will not be attracted to men. Or if somebody is attracted to men, they will not be attracted to women. That's not the case. There's over 40-50 years of social science research that says that people attracted to more than one gender are many more in number, in prevalence, than people attracted to only the same gender. So in other words, bisexually oriented people are much, much more common than gay or lesbian or homosexual people. Okay, and so this brings up an added complexity. If you see a man in a relationship with a man, you may be tempted to conclude that that man is homosexual in orientation, but actually what you're seeing in the relationship is just their behavior. So one or both of the men could be bisexual, but they just happen to be in a relationship with somebody of a same gender. Similarly, if you see a man-woman couple, you cannot assume that both of them are heterosexual. One or both of them could even be bisexual or pansexual. So this is a three-dimensional axis with sexual orientation. You have a similar three-dimensional axis with sexual behavior. So a person can have sex with nobody, which is what is called celibacy. So a person may have a sexual orientation which is heterosexual, but sexual behavior which is celibacy, because they are a nun in a convent, or they are a priest, and for religious reasons they do not have relationship with anybody. So it doesn't mean that their sexual orientation is asexual. It just means that their sexual behavior is celibate or celibacy. And we've already seen that someone could have a sexual orientation towards somebody, but because society does not accept it, they may be forced into sexual behavior with somebody else because of forced marriage. So sexual orientation and behavior don't necessarily match with each other. Then in terms of sexual identity, there are terms like gay, bisexual, lesbian, pansexual, sexually fluid, double-decker, etc. We need not go into all of these details except to say that gay is an identity of predominantly men who are homosexually oriented. Bisexual is identity adopted by people who are attracted to men and women. Lesbian is an identity of women who are homosexual. Then pansexual is an identity of people who are attracted to people regardless of their gender. Sexually fluid refers to people whose attractions may vary over time. And then double-decker is a term that is not used these days, but it's a term that some men use in the Indian context to indicate whether they have a sexual preference to penetrate or not penetrate. Okay, so we can come back to these if there are questions later, but I just want to reiterate that here are some terminology slides, and I'm happy to have this shared with all the participants. I can share them in the chat after this, and also share this with the organizers so that they can share it with all of you for your record. Now, so far we talked about sexuality, which was a combination of sexual orientation, sexual behavior, and sexual identity. Now we are going to go to gender, and we are going to look at definitions particularly from the health and the psychological or psychiatric professions. So World Health Organization defines gender as socially constructed roles, activities and attributes that a given society considers appropriate for men and women. So if you find a male child who is not interested in playing cricket or running around kicking a ball, but would rather, try on his sister's churidar or salwar kameez, or follow what his mother is cooking, you'll often have people come up and say, older relatives and come up and say, be a boy, be a man, right? So what people often have in mind is that a male child or a male boy or adult will have a natural proclivity for certain things that are considered masculine, like being aggressive, like an interest in sports, a lack of interest in feminine clothes, a lack of interest in things that are considered stereotypically feminine, like makeup, etc., etc. So you can already see that sex and gender are two different things. Sex is primarily what we think of as biological sex, and it's based very often on the external characteristics. So if an infant is born with a penis and a scrotum, you say, okay, it's a boy. If the child is born with a vulva, you say it's a girl, and you leave it at that. And then gender is again the social attributes supposed to be associated with male children and female children. And if a child grows up expressing gender in a different way, so a male child grows up with a lack of interest in cricket and a preference for dolls, then such a child comes up for ridicule and approbation, whether it's within the family or among peers in school or even from teachers. And in the most extreme cases, children who do not conform to what society expects of their gender are likely to be physically harassed or even sexually violated. A lot of LGBTQ people have had nightmarish experiences of physical and sexual violence in school, which is part of the reason why many, especially transgender children, drop out of school, are unable to complete their education, are unable to find a job that will accept them, and end up opting for sex work or begging. So we often hear, why are these people begging in the streets or doing sex work? Why can't they find regular employment like everyone else? So you have to think of a constellation of factors right from childhood that conspired to make the children outcast at school or prevented them from having a safe environment, resulted in dropouts, violence at home making them run away, where the only option for them was to join the Hijra community. So gender is a multi-layered thing, and we are talking here about gender as primarily social. But there is actually an aspect of gender which we have come to understand in the last 10-15 years, probably more 40-50 years, but more widely discussed in the last 10-15 years, which is an inherent sense of gender, which we call gender identity. So a child may be born with male genitalia, may be given the label of boy by the doctor, by parents, and by society, but the child may grow up feeling like a girl. So in such a case, we are not talking about how the child expresses themselves, but the child's own internal, deeply felt sense of being a boy or a girl or both or neither. So this deeply felt inherent sense of being a boy or a man or male or a girl or a woman or male or none of the above or more than one of the above is called gender identity. So all of us or many of us, let's say we were assigned female at birth, everybody called us as girls, and we grew up to think of ourselves as girls or women. So in this example, our gender identity, the socially attributed gender, and our biological sex all aligned with each other. So our biological sex was female, society told us we were girls or women, and we also thought of ourselves as girls or women. So in such a case, the gender identity is aligned with the biological sex, and such a person is called a cisgender person, CIS. But a person whose gender identity is not aligned with biological sex is a transgender person. Anyone who's had some organic chemistry will understand cis and trans as two configurations of molecules, and so the word transgender was first coined, and then people came up with cisgender to explain the majority of people who are not transgender. So in summary, a transgender person has a gender identity different from what is expected of based on their biological sex, and that's a transgender person. And a cisgender person, the gender identity is aligned with the biological sex. So once again, to recap, transgender is a gender identity contrary to gender assigned at birth based on biological sex. And when we say biological sex, most often what we see is the genitals. But sometimes you would need to look beyond the genitals and look at the chromosomes. We also know that, chromosomally speaking, we all have autosomes and sex chromosomes, and females will have XX and males will have XY, though this is also an oversimplification. And also histology, the presence of ovarian tissue or testicular tissue, etc., etc. So based on biological sex, we will assign a gender. Like if the child has a vulva, you say this is a girl. If child has penis and scrotum, you'll say this is a boy. But the child grows up to have a different gender identity, you say the child is transgender. So you always refer to a person not by their biological sex, but by the gender that they have chosen for themselves. When I say chosen, I don't mean like shopping in a store and deciding I like blue saris instead of green saris. We call it a choice, but still it's a very deeply felt inner sense of who they are. So a transgender woman or a trans woman is somebody who to be referred as she or her or hers, and such a person is typically born biologically assigned female, biologically assigned male, who identifies as a woman. A trans man is somebody who is biologically assigned female but who identifies themselves as a man. Okay, are there any clarifications needed here? Can I just stop for a second and look to see if there are questions? So let us just revisit the 2 or 3 examples given. So I think some of you spoke, 2 people spoke about individuals who were biologically female who turned out were felt like men. So you would refer to such people as he or him or his, regardless of whether they have had a surgery or not, and that would be the respectful thing to do. So nowadays in a lot of corporates and companies like that, even in email, we are asked to specify your pronouns. So someone will say, I'm Priya, pronounce she, her, hers. The reason we do that is very often we respond to subconscious cues or cues that we don't even think about. So if somebody has a name that ends in a vowel, you think of that person as being a woman. Or you're speaking on the phone with somebody with a deep voice and you think of that person as a man. Or someone with a high-pitched voice and you think of that person as a woman. But we should not make all of these assumptions, because these assumptions are made typically based on secondary sex characteristics which may or may not be aligned with their gender identity. So it's best to ask them, what gender would you like to be known by, or what pronouns would you like to be addressed by? I'm going to pause for a moment and see if anybody has any questions or wants to make any observations. And Sheetal, Smriti, if you'd like to say something about any example where what we've discussed so far has turned out to be relevant, maybe you could share an example from the work you've done or the training you've done. Yeah.
I feel one of the things that really resonates with me is what you said right at the beginning. Even for a lot of women, going to a gynecologist, and what you said about the first question being asked is, "Are you married?" What the question really is, "Are you sexually active?" And this is something that I've experienced repeatedly, and there's an implicit judgment already there. So my first encounter with a gynecologist was at the age of 19. And I said, of course, I'm not married. And then, after that, of course, any other question just seemed like, so the tendency then is to close up. Then you don't want to talk about things. You don't want to talk to them about some of your concerns. And I think what you're saying here is very important, because it's not just, the more, I would say, obvious, or I think Kimberly had talked about what she experienced in Assam. But I think these are things that we normalize, even in, for those of us who don't identify as transgender, who don't have, I would say, inner conflict about where we lie in this whole, in this whole sphere. And I think what that translates into is, if you can't express yourself honestly at a very basic medical examination, what hope do we have of being seen for who we are when we are suffering from serious illnesses? And that's what I want to tie up to the palliative care issue, where the other thing that you said is, and I'm guilty of it. We talk about patients and their families. And if we ask anybody in the room, what do you mean by family? You mean your biological family. But in a lot of these, for a lot of these individuals, their biological families have rejected them. Mm-hmm. Then who are we talking about when we talk about palliative care? When it comes to palliative care is for the person and the family. Who are we including? So I just, more than that's just a reflection that I just want to place with the group today.
Yeah. Thank you very much. Anyone else would like to reflect on what Smriti has just shared, or what we spoke about earlier? It's just a quick stock taking before I move forward. Okay, then let's just go back.
I had one question.
Please.
Yeah, sir. Actually, as a doctor, I would like to ask that how do we get practical experience with these? Because at times it is very difficult. Even if one patient comes who is from transgender or a lesbian or a gay or whatever, we do not know how to examine or how to ask questions. So how do we get practical knowledge of all these? Because in med school we have not been taught. So how do we get this?
Right. No, that's a fantastic question. And I think if you are in a place like Bombay, for example, like Mumbai, there are, or even Pune or even Nagpur in Maharashtra, and in plenty of other places, there are LGBT groups. And you can go and reach out to those groups. If you like, you can even volunteer once a month, where you just go there and set up a makeshift OP where people can come to you and with their issues, because a lot of people have very poor healthcare seeking behavior because of past experiences of stigma and discrimination. So you can actually be quite upfront about the fact that you don't know very much about LGBTIQ healthcare, but you know healthcare and you would like to be sensitive and inclusive. And if you go to one of these LGBTIQ groups, they'd be more than happy to explain, and they'd be more than happy to have you be in conversations with community members. And if you'd actually like to give back by volunteering, that's an amazing opportunity to also do it. And there are a lot of people who have one of the things we have done here in Chennai is that because the trans community in particular has very poor track record of accessing healthcare, and many of them have non-communicable diseases. When we talk about transgender, we always think about HIV and NCD, but no, a lot of them have hypertension, a lot of them have diabetes, a lot of them have these problems, and they don't go. So we have actually conducted health camps where we bring in doctors who may not know a whole lot about the community, but they know their technical field. And we first do a 101 for the doctors, and then we have one person from the lesbian community, actually this was a trans example, right? A trans man, a trans woman, and a non-binary person explain about themselves and their journey. And then we have a series of tables, so they can go to for their blood pressure measurement. There'll be a dentist out there, there'll be someone else, they'll take blood samples, they do a test right then and there. So actually organizing these and being part of these health camps is also a great way to be exposed to a large number of people, provide care, and also learn on the job. So I think this is something you can look at. If you are in Dr. Nupur, did you say you were in Mumbai?
Yes, sir.
Yeah. So there is a Humsafar Trust in Thane, and I think in Navi Mumbai, you can always speak with Vivek Anand there and say that you'd like to visit their facility, visit their drop-in center. They actually have doctors and counselors come there once a week or something like that, but it's primarily around STI and HIV. But and your specialization is, may I ask?
Sir, I've done my MBBS.
Okay.
From St. Petersburg.
Okay. But yeah, you could, the Humsafar also has a group of lesbian and bisexual women and trans men. So if you say that, these are, this is my skills and training and I'd like to know more about LGBTIQ issues, you can definitely go meet them and even volunteer. Even if it's for 2 hours a month, it would be priceless experience. And for people who have similar questions to Dr. Nupur, but who are in other parts of the country, we can definitely refer you to people in your, wherever you are in the country, whether it's Nagaland or Mizoram or Assam or, Kerala or Tamil Nadu or Andhra Pradesh or Telangana or Chandigarh, anywhere. There are definitely at least one group, probably more than one group. What you will find a little rarer to find are groups exclusively for lesbian and bisexual women, because there are a lot of social factors conspiring to keep lesbian and bisexual women in the closet. It's much harder for them to break out of the families. So if you look at the entire country, there are probably fewer than 6 groups for lesbian and bisexual women compared to groups that are kind of overall branded as LGBT but are predominantly men. You'll find a lot of groups for trans women, but you will find very few groups for trans men for similar reasons, because trans men are considered by their family to be girls and subjected to a lot of the socio-economic restrictions and cultural restrictions. Okay, so
before you move on, for those of us who probably don't have access to getting this kind of education or sensitization from the community themselves, and if our encounters are just, say, more rare and one-off, one question I just want to ask on behalf of everybody, I suppose, is how okay is it to just place some of that, control in the person's hand and say, can you tell me what I need to know for me to help you? Yeah. Or, how would you like to be addressed? Or, really sort of, because I think that's where some of us get a little bit stuck and we say, should I have known this, or can I ask the person this, and is it offensive to them?
Yeah. No, absolutely. I think that's the best way to start, by not making assumptions about their gender identity, about their sexuality, about the gender of their partner, about their pronouns, and you can ask all of that up front. Some people will look at you like you're nuts, but but a lot of people from the community will deeply appreciate this gesture. Yeah, that's total. It's a very good idea to do that. And also there are people who are from the community who are working in health professions and the caring professions. So there are people like that who might be just willing to also consult with you if you wanted to get a second opinion or speak with somebody else about the situation. There are also other professionals in the country, like for example, there's Dr. K.P. Ranade from TIS, from Tata Institute of Social Sciences, who has developed the definitive guide to counseling for LGBTIQ people. And they go by the pronouns they, and they are extremely supportive and have helped people around the country, more people than one can keep track of. So yeah, so that's there is help around. There are websites around. And a lot of people from the LGBTIQ community now are on Instagram, and you can hear their thoughts, see their videos, etc., and learn a lot from that also. Okay. So I spoke about sexuality, including sexual orientation, behavior, and identity. We talked about gender and gender identity, where we said people may have a gender identity different from what is associated with their sex assigned at birth, in which case we'll call them transgender. Otherwise, we would call them cisgender. Now I'm talking about gender expression, which I also alluded to before, is how somebody behaves, the kinds of cues they give out in terms of their mannerisms, the way they walk, the pitch of their voice, the way they use their hands, etc. We all have an idea of what it is for someone to look manly or talk manly or behave manly, and we all have an idea of what it is for someone to look womanly or feminine or effeminate, etc. So like I said before, anyone who is just give me 1 second, you know. Actually, so even if you're looking at a child who's in 1st grade or 5th grade, or someone who's in 9th or 10th, even if such a child has not actually arrived at figuring out who they are in terms of sexuality and gender identity, they may be unconsciously exhibiting gestures, and in other words, their gender expression may be something that comes in for a lot of ridicule or hostility or violence. So whenever we do sessions for teachers, we say that it's not important for you to know whether your particular student is gay or lesbian or bisexual or transgender. That orientation and that identity are irrelevant. What is important is whether that child's gender expression is causing them grief, is causing them harassment, bullying, etc. So you might actually have an individual who grows up to identify as a heterosexual man, right? A man who's attracted to women, who's not transgender or anything, but that person may, as a child, have exhibited some feminine characteristics, and as someone who's a teacher at that stage, the job of the teacher is to make sure that that bullying stops, whether it's in school or whether it's in college. And the focus should not be on trying to get the child to change. Yes, some children may grow out of gender non-conforming behavior. Some children may continue in that way. Some people may end up identifying as gay or trans or as heterosexual. But what will eventually happen to them is less important than the here and the now, and the challenges and the stressors they are facing right now, and how, as a teacher or a caregiver or a healthcare provider, one can help. We talk to a lot of child psychiatrists and child psychologists whose parents, who get parents of children who are gender non-conforming, who says, my child is abnormal, please treat my child, make my child normal. And many of these child psychologists and psychiatrists are well-intentioned. At heart, they want to make sure the children do not face bullying and violence, but they go about it wrong, because the problem is not really with the child, but with the system that does not understand or acknowledge or respect diversity, including diversity of gender expression. So we have to do a lot of work with pediatricians and child psychiatrists and child psychologists around not forcing the child to conform to a particular kind of gender expression, and instead cultivate tolerance and acceptance among the students and faculty and staff for diversity. Okay, so a person who is gender non-conforming is a person whose gender expression is not aligned with the gender expected of them based on assigned sex. And I make this point because when we talked about gender identity, we talked about how the individual thinks of themselves. But here we're talking about how the individual behaves. So the term gender non-conforming child is often used for children whose behavior, play, etc. is viewed as contrary to assigned gender. For example, a feminine behaving child who's assigned male at birth, a masculine behaving child assigned female at birth, right? So a child who's gender non-conforming may as an adult identify as heterosexual, lesbian, gay or bisexual or transgender. You cannot always predict adult gender identity or adult sexual orientation from childhood gender non-conformity. However, many in the LGBTIQ communities report being gender non-conforming as children. So you can think of gender non-conformity as an umbrella. Some of those children grow up to be LGBT, many do not. In fact, about only about 20% of gender non-conforming children will grow to identify as transgender as adults. The rest may be cisgender, gay, bisexual, lesbian, or even heterosexual. But if you look at the subset that identifies as transgender, the majority of them would have had experiences of being gender non-conforming as children. Okay, so also gender non-conformity is not an identity. A child as young as 2 or 3 may be gender non-conforming without having any sense of the child's gender or sexuality. I may not have time to play a video right now, but so I'll just move on. Now, I'm coming to a term that somebody mentioned earlier, or a concept that somebody mentioned earlier. For example, they spoke about a female assigned child who was very uncomfortable with female body parts. Or that you may have a male assigned child who is very uncomfortable with the penis, who does not like to stand up and urinate, who would prefer to sit down and urinate, and who prefers, stereotypically feminine activities. So this acute discomfort or distress is what is called in the psychiatric literature as gender dysphoria. And it is a term in our Diagnostic and Statistical Manual, DSM versions 4 and 5. In the World Health Organization, ICD, it used to be called gender identity disorder, but as of January 1st, 2022, the disorder status has been removed and it's called gender incongruence. So, in summary, gender dysphoria refers to the acute discomfort with assigned gender, and a person with gender dysphoria may have a desire to change their body, to take, if it's a gender dysphoric female assigned child, the child may not want breast development, the child may want a deeper voice. As an adolescent or adult, the child may want testosterone therapy, may want to remove their breasts through mastectomy, may want to have hysterectomy, oophorectomy, etc., etc., and may even want a construction of a penis, which is called phalloplasty. Similarly, a trans girl or a trans woman may want to get rid of body hair and facial hair, may want more, female-looking contours, may want breast development, may want do not want the penis and scrotum, may instead want a vagina or a vulva with with the clitoris, with the labia, etc., etc. So the point here is that not all transgender people necessarily want to have surgery. Many of them want, but not all. Similarly, not all of them want hormone therapy, but some of them want. But as per the law of the land and the Supreme Court, as long as that person's gender identity is different from what is expected of them, they are transgender and they can legally change their name and gender even without undergoing surgery or endocrine therapy. But if they want to have hormone therapy or surgery, they need a letter from at least 2 psychiatrists or 1 psychiatrist and 1 clinical psychologist saying that they have gender dysphoria and it's been persistent. Okay, so gender dysphoria is the term from American Psychiatric Association. The World Health Organization has now used the term gender incongruence. Now, in order for a psychiatrist to make a diagnosis, if you will, that the individual has gender dysphoria or gender incongruence, the only thing they have to do is ensure the individual is an adult, has no other psychiatric condition, does not have schizophrenia or delusional disorder, and is able to make decisions about their body. So this is enough in the current informed consent model of psychiatry, which allows gender dysphoric people to then qualify for surgery or hormone therapy. If this is a little dense and I'm going very fast, feel free to interrupt me. We can come to this later also. If so far, recap, I've spoken about sexuality, gender, gender identity, gender expression. Now I'm talking about sex and sex characteristics, which ideally I should have begun with because everyone thinks they know sex. So chromosomally, if you look at sex, you have females having XX, males having XY, and we have the sex determination system where haploid sperm meets with a haploid egg, and you have a diploid this thing, and if the infant inherits an X and a Y, then you have a male. If it inherits an X and an X, you have a female. You would also have, hormonally speaking, a lot more testosterone in males and a lot more estrogens in females, and you'd have the combination of external and internal body parts associated with males and females. However, this kind of alignment between external and internal body parts, hormones, tissues, and chromosomes is not always the case, and almost 1 in 100 individuals do not have this kind of alignment where a certain chromosomal configuration equal to a certain anatomy and morphology, histology, etc. Give you an example. There is a condition called androgen insensitivity syndrome, where an individual is born with XY chromosomes, but the developing fetus does not respond to androgens. So depending on how insensitive it is to androgens, the child may grow, may be born with a range of genital types from no virilization to complete virilization. So all of these are XY individuals, but the XY individual can look like a complete female phenotype to a complete male phenotype to anything in between, depending on the degree of androgen insensitivity. So this is a variation called an intersex variation. Subtype is androgen insensitivity syndrome, and all these like stages 1 to 4 are called ambiguous genitalia, and where the child is born with genitalia that don't fit neatly into the male and female boxes. And a practice that is widely prevalent in India but being phased out in other countries is the practice of the doctors performing genital surgery on the infant to normalize the genitals to make it look fully male or fully female. Okay, so right now the consensus in pediatrics and pediatric endocrinology and surgery is that if an infant is born with ambiguous genitalia, as long as there is no accompanying life-threatening situation, like a child may be born with a blind urethra, in such a situation a surgery may be needed. But otherwise you defer surgery, wait till the child is old enough, and we don't mean 18 but more like puberty, where depending on the child's gender identity and the child, whether the child has gender dysphoria or not, you could maybe opt for some surgical procedures. So the bottom line is, intersex infants born with ambiguous genitalia, the current wisdom, medical wisdom, is do not automatically try to normalize their genitalia. It is tough to explain to parents, but in the interest of the child's long-term emotional and physical well-being, it's best to defer surgery. Now, androgen insensitivity syndrome was one of many intersex variations. You also have what you may have studied in school as sex chromosome syndromes, like Klinefelter's, which is XXY, Turner, which is XO, then you have XYY, etc., etc. So all of these are also intersex variations. Now, if you look at the entire spectrum of intersex variations, we have a prevalence of 1 in 100. Earlier, it was thought to be 1 in like many million. So the terminology for this also has evolved. It used to be called disorders of sexual development, that is DSD. Now people, even in the medical professions, are opting for differences in sexual development, also DSD, but it's a non-pathologizing term. In India, we have a High Court verdict from Kerala High Court, from Tamil Nadu High Court, that says an intersex child, you should not be doing a surgery on it, on intersex child, and it has also translated into a government order from the Department of Health and Family Welfare and the Directorate of Medical Education. So we, some of us activists, are fighting to make sure that this ban on surgeries, non-essential surgeries, is enacted throughout the country. Okay, so we talked about about sexuality, which is sexual orientation, identity, and behavior. We talked about gender, including gender identity, gender expression. Now we have talked about sex characteristics. So we refer to people with atypical sex characteristics as intersex people, or people with differences in sexual development. So DSD, intersex, and atypical sex characteristics all refer to the same thing. Okay, now let me quickly check on the time. It's okay, I can't see the time. Could someone tell me the time?
You have about
it's 4:10, sir.
Sorry? Okay, 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 got it. Okay, so I'm coming to some typical arguments that people have against LGBTI people, one common thing is it's not found in our culture. But here you have an example of a young woman from an indigenous Manipuri culture where trans girls are actually revered, are considered to be blessings from God, and are treated very, very well within their biological families. Here you have depictions of same-sex behavior among men and women in Khajuraho, and of course we have the Shiva as a bilateral androgyne, which is another sculpture. So there are references throughout history, mythology, etc. But we can't also say that all of this was hunky-dory before the British came along with their section 377 of the Penal Code. We can't say, because if these relationships, for example, between two men involved two men of a higher caste and a lower caste, the upper caste man lost his caste because of having sex with somebody of a lower caste and is supposed to do some penance. So as long as people engaged in these non-normative behaviors but continued to marry and have children and were engaged with people of the same caste, it wasn't a problem. But the moment they stepped outside those boxes, these were condemned. So there are a lot of books by Devdutt Patnaik, who is a medical doctor turned mythologist. So he has a book called The Pregnant King, and where you can read a lot of narratives from Hindu mythology that talk about cross-dressing, that talk about gender conversion, and also relationships between people of the same gender. And there are also instances from Christian and Islamic texts like Jonathan and David, and there are other examples where they actually talk about, well, biblical scholars have interpreted it in a sense of sort of homoerotic relationships. The other argument people make is that all this is not found in nature. We have evidence from almost 450 species of mammals, reptiles, fish, birds, and insects that describe not just same-sex behavior, but bonds between individuals that last for multiple breeding cycles. So it's not just a one-off thing or a case of mistaken identity. But so we do find all of this in nature, whether it's chimpanzees or swans or dolphins or penguins. So why the problem? So society, we know, emphasizes male-female relationships, certain kinds of gender expression, marriage, childbearing, leading to bullying and other abuse by peers. All of this can lead to suicidality. And in addition, within the medical system, we have the practice of conversion therapy, where psychiatrists will promise to change a child's gender identity or sexual orientation through some combination of medicines and electroconvulsive therapy or shock therapy, which doesn't work. So we can see a summary slide where, you know, the prejudice against homosexual, bisexual, and trans people, called homophobia, biphobia, and transphobia, respectively, stigma and discrimination, difficult experiences of coming out and disclosing one's identity, and social isolation, exclusion, and rejection lead to a constellation of issues including low self-esteem, depression, anxiety, eating problems, misusing drugs and alcohol, self-harm, suicidality, and other mental health problems. There are data from other countries about suicidal ideation and attempts being higher for transgender than cisgender, and gay, lesbian, bisexual versus heterosexual, both among boys and girls. So I'm actually going to stop with this and use 15 minutes for discussion. There is some more content, but it's content that you can probably pick up on your own. I think it's important for to hear back from people. Harpreet just wrote, as in Gujarat, even if you go for a common cold and cough or viral issues to a clinic, the mandatory name in the file is the first name followed by the husband's name. Yeah. Pratibha has said, using gender neutral terms like spouse or partner instead of husband, wife, brilliant. Then Dr. Nupur shared, of course, that they were one of the most neglected company. Local body need to know the needs of LGBT community. Sometimes they are disowned by family members. All very relevant, right on target points. Let's use the next 15-16 minutes to discuss what we as care providers in palliative care or in, you know, other areas of the helping professions or healthcare professions are thinking after listening to this, and what you think you might want to do differently in your practice in the future, or at least think about doing differently. So can we hear from people? Just maybe you can take a couple of minutes to reflect also. Yeah.
May I request those of you whose bandwidth allows it to please turn on your cameras, because it's always nicer to connect.
Yeah, I see that Saraswati removed her mute. Saraswati, would you like to say something?
Nothing.
Anyone else? Hands up.
So, Ramki, just to warm up the room a little bit, a lot of us who are in palliative care also are deeply concerned with end-of-life care issues. You know, what kind of end-of-life care people get, and there's a lot of talk now about appropriate end-of-life and things like that. We're talking about advanced care planning, and those are sessions that this group is still yet to undertake. And it's towards the end of our FCPC sessions, but going into it also, we've made a special section on what it's like for the LGBTIQ community. But what has been your experience of, you know, people with advanced and say chronic or debilitating illnesses, especially when it comes to decision-making capacity, when they are not able to make decisions for themselves? And that's something I'm particularly interested in, just, you know, getting your views on.
Yeah. So unfortunately, the law gives primacy to the heterosexually married individual spouse. So wife making decisions, husband making decisions, or, you know, biological family, immediate family, parents, siblings making decisions. There have been many cases where the people in a same gender relationship, like two men, had to deal with forced hospitalization or even death of a partner, where the parents who had for the last 20 years completely you know, cast off their child, swooped in and began making decisions right and left, you know, did not recognize the partner, and they were just intent on seeing what they could get out of that. There are transgender people who in death were treated to a very undignified burial or cremation, where their hair was cut, they were draped in male clothes, which was not their preferred clothing, and then their family, you know, kind of just completely negated their identity even in death. So there are a lot of examples like this. Now the Hijra community is a subset of the transgender community, particularly the people who are trans feminine, who are born male and very rarely intersex, but who identify as third gender or female. And there is kind of a support system of people, because many of the people who joined the Hijra Gharana came away from home at a very young age and were disowned by their parents, where the other people within that system perform the last rites of the individual, and the healthcare providers also know that this person does not have biological family, they're part of the Hijra or Kinnar setup, in which case they just surrender the body to the people from that Gharana. But in the majority of cases, this does not happen for non-Hijra LGBT people. Yeah, there is a very good and important clause in the Mental Health Care Act of 2017, I think, which says that if it's a mental health issue that requires hospitalization or just making decisions, you can actually give an advance directive, or you can authorize somebody who's not a biological relative to make decisions to this authorized advance directive. But this does not apply to physical health care and hospitalization and needs. It needs to change, but we can take a leaf out of the Mental Health Care Act here and try, if there is a situation where there are both physical issues and mental health issues, you could try to cite the Mental Health Care Act Mental Health Care Act, to give some recognition and dignity to their partner who may not be recognized by their biological family. Okay, let's maybe look at a scenario. You are, there is a person who has come to maybe a government facility in a state where there's good palliative care, and that's a woman in her 70s, and she's been diagnosed with, you know, stage 3 or stage 4 cancer, and she does not bring any family with her and says she's not married. And let's say you're doing the intake and trying to, you know, help her with the support system that she needs to go through this. How would you do it? What are some of the things you would ask? What are some of the things you would not ask? How would you proceed with this case? Don't assume the person is lesbian. Don't assume the person is anything. Don't assume they're heterosexual either. Don't assume that because they don't have a husband, they don't have a male partner. So yeah, just make no assumptions. Start from ground zero. What are some of the things you would do and not do as part of your intake and a part of finding out how best to support this person? Anyone? I mean, there's nothing wrong in asking, do you have natal family members? You know, who are the people, important people in your life? So yeah, maybe that can be a starting point. But please, maybe someone can share what you typically do during such an intake and what you might do differently from now on that you haven't been doing, to leave open the possibility that the person may come from a non-mainstream gender or sexuality. Yeah. Smriti, I'm going to put you on the spot.
So we have, firstly, you know, this batch has been through a basic communications workshop as well. And, you know, typically in palliative care, we focus on the breaking bad news and communicating bad news. And we find that to be the most difficult question. I mean, most difficult conversation. I can tell you after all these years in palliative care, that's not the most difficult conversation for me. It's what you just talked about. Because we have not been educated in, you know, what is a sensitive way to go about doing it. A simple example I can give you is communicating with children about grief. We don't know what the boundaries and limitations are. So similarly here, I would say that in the absence of formal training, where I would really begin is like what you said, you know, is there anybody who's a significant other in your life? And, you know, this is you seem to be going through a difficult illness trajectory. And, you know, so who is your support system at this point in time? But I would say that before we even get to that point, there has to be some rapport building where we demonstrate respect before we even get there, because they've probably been ill-treated in the past for the answers they've given. So it would take some amount of rapport building, some amount of, you know, creating a safe space. If I have a suspicion that this is somebody from the LGBTIQ community, then I think my number one job would be to make them feel like they can trust me, no matter what their responses are going to be. That's where I would start, but happy to hear from others.
Yeah. So first, treat them like any human, build a rapport, indicate to them that you are open, that, I mean, you could say things like, you know, if they say that they are not married, you could say things like, yeah, not everybody in the world is married. There are some who choose to be single, some who have very close friends, and those very close friends could be men, those very close friends could be women. It's okay. Yeah, whoever it is, we want to know who is there that, you know, you trust and whom we can, you know, take into confidence. So sometimes people may not even be in the mindset where they dare talk about a significant other or romantic partner. They may, all their life, they may have gone through saying, this is my friend. And so use the word friend also if necessary, or close friend, or those kinds of things also. And maybe at some point later, it turns out that the close friend is more than a friend, which is okay, but you've at least opened the conversation for them to speak about somebody. And even if that person is not a romantic partner, but a very good friend, I think there should still be a scope for, bringing that person into the network, the care network, yeah.
Sorry, Sinya, I'm sorry, I'm a little bit confused between all the batches. Have we done grief and bereavement with this batch yet? No.
Excuse me, ma'am, I didn't hear you.
Have we done grief and bereavement with this batch yet? No.
No, ma'am.
Okay, sorry. Good thing I didn't jump the gun on that. But I would also say an important aspect here, Ramki, is for us to perhaps taking back from this session, also reflect on, our own biases perhaps that unintentionally we carry, because all of us may want to be compassionate, but I think understanding where we come from, what we've internalized from our own upbringing, from the filters that we've been subjected to, there is some amount of prep work and research and understanding we need to go through before we put ourselves in that situation, right? Because we can inadvertently end up being offensive or insensitive.
Right. Sure. And maybe some of your other classes or lectures will have the option to broaden the discussion or look at case studies that are LGBTIQ inclusive. Maybe that can be worked into like a grief and bereavement related case study, something else. Yeah, it can be done. So yes, any other points, especially for people who have grown up, and it's not wrong. I've also grown up in a situation, in a family circumstances where I was told that all these things are abnormal and we should not associate with these kind of people or those kind of people. So it's completely all right to acknowledge that and to try and get past one's beliefs when it comes to the delivery of care. So if there are no questions, then maybe just some reflections on what this particular session has triggered in you in terms of thinking differently, or from what you have been thinking so far, or some place where you already had insights but maybe you have an additional insight. Would a couple of people who haven't had a chance to speak right now volunteer to share that? Doesn't have to be a question. It can just be a reflection or a comment in the next 2 to 3 minutes. Yeah.
Sir, I actually had a question. So as a caregiver, you're not just working with the patient, you're also working with the family. But what if the family is not acceptful of the patient's identity and orientation? Then how do you sort of navigate in a situation and balance both the aspects?
So you're saying here that the family doesn't know or the family doesn't accept?
Even if the family doesn't know, at least, because that can be very tricky.
Yes. So if the family, as in the natal family, doesn't know, and if you manage to get I'm sure you will have an opportunity to speak with the individual one-on-one without the family around, right? So if the person shares with you something in confidence and doesn't want the biological family to know, then that has to be respected. There's not anything you can do about that. But if the parents know or siblings know and they are in denial, then maybe again in a palliative care situation, maybe you can try explaining to them that yes, you maybe did not accept your child because of this difference, but this is a particular situation where they are needing palliative care or end of life care, and the people who are most important to your child are you as parents and also their significant other. So please try to make an effort to have them also be part of the process. So maybe something like that can work. Yeah. But yeah, if they have not disclosed to their biological family and at the same time they are dependent on the biological family for care, then maybe it's not a good idea to disclose their sexuality. or gender identity. But let's say they have not disclosed to their family, but they have gone away from their family and they are living on their own or with a partner. Maybe you can also ask yourself the question, do the family even need to know this? I mean, unless they are in a position where they are going to come there and kind of take over, assume center stage and begin dictating. If that's not the case, maybe sometimes things are better left unsaid. Right. Again, it depends on the age, the value system of the client also, and what the client wants. Yeah.
Ramki, we are at the end of our time, but I just want to ask one last question. In all the years that I've been involved with palliative care, I've never seen a lot of people from the transgender community or intersex individuals in IPs and OPs. And we know that that's because the health-seeking behavior has been that it's a constellation of circumstances, like you said. I want to ask you, where do most people from the trans community who get cancers and stuff, where do they go towards the end of their lives at the moment?
Yeah, again, if they are part
where
of
do they get care at the moment? Is it just at home with the communities, or where do they go?
Yeah, I mean, if they are in part of the Hijra community, the community will provide some amount of care. I come and look them up, but very often they are not also able to afford treatment if it's something like chemo or something. Some of them have reached out to Lions clubs and Rotary clubs, which have supported financially the kind of medical treatment that they have needed. But again, the number is probably vastly outnumbered by the people who receive no care whatsoever. We know people who are just completely neglected, and they just knew the person had passed away a few days ago when nobody opened the door and they could smell a rotting body. So yeah, that unfortunately is also a not uncommon situation. Yeah.
Thank you, Ramki. I think you've brought the session to a close with a very important point. We've talked about palliative care as being one of the bridges to universal health coverage, because really what palliative care, in the way we practice it in especially low and middle income countries like India, is vastly different from how it is practiced in the West, simply because we don't have those systems in place. And here's something for all of us to think about. A huge component of palliative care in our settings is home care, is meeting people where they are when they need it. And today Ramki has told us something very important. There is a move in the West, especially in the US and in several Western European countries, to make palliative care available for prisoners. But, and it's been an uphill battle, but here is something that we need to think about. How do we, especially as community-based volunteers and practitioners, is there a way that we can reach out to those who are historically have been, put through experiences that makes it difficult for them to ask for help in medical facilities, and how do we integrate it with our practice? So we're going to stop with this. Ramki, thank you so much, as always, for opening our eyes to an issue that I think many of us really need to be educated on. And I can't thank you enough for your time. And thank you for the incredible work that you and your organization and your colleagues have done. You mentioned it in passing that the Tamil Nadu government passed this ruling and stuff. We know, some of us know how much of that you were involved in. Thank you so much, and thank you everybody for being with us today. And if you have any questions, please write to us. We will pass them on, and we will try and get you the answers. And thank you all very much once again. Thank you.
Yeah, thanks again. And I'll send out the PowerPoint to the organizers in case you need to share it. Yeah. Thanks, everyone. Bye.
And thank you, sir. Thank you, Ramakrishnan, sir. And Smriti, ma'am, thank you for being with us today. I was surprised to see you on the screen. And thank you. Ramakrishnan, sir, thank you. Thank you so much for your priceless time. And everyone, please give your feedback. The link is provided in the chat box, and it will be provided in your WhatsApp group also. Thank you once again. See you soon on the next class. Bye-bye. Take care.
Bye. Thanks.